Good morning. So we've had the chance to watch the first two panels from the green room, and it's a really exciting day and some really good, robust conversation. So we are hoping to keep that ball rolling. Welcome and thank you for joining us. I want to introduce this very illustrious panel, and I'm excited. We have three great experts here who I think will give us some valuable insights. First is Dr. Amy Ducro. Amy is the Executive Director of Population Management for Colorado Permanente Medical Group, Kaiser Permanente. Dr. Amy, we have two Amys today. Dr. Amy McKenzie, Vice President of Clinical Partnerships and the Associate Chief Medical Officer for Blue Cross Blue Shield of Michigan. And Tariq Rabah, who is President and CEO of Otsuka American Pharmaceuticals. So welcome to all three of you. Delighted to have you with us today. So this panel is going to build on this morning's conversation, and we're going to be talking about the role of the private sector in a people-first healthcare system. So before we get into the nuts and bolts, what I want to do is a little bit of level setting. And I'm going to ask each of the panelists to talk a little bit about what they see as a person-centered or person-first healthcare system. Why don't we start with you?
Sure. So I think that a person-first healthcare system really has to be listening to patients, listening to experiences, engaging with patients who are not necessarily in our system. So I work at Kaiser Permanente. We have over 12 million members in 8 states. And just to give a little bit of background about our model, we have robust systems that help us manage populations. And we've talked about the difference of really looking at a system from a broad level, but then really it's essential that we have those voices of the members that we're serving. So when we look at how we can best accomplish that, I'll give examples of two patients that I have. And I'll change their names, but the stories are the same. So let's say I have James, who is a person in his late 30s. He's Black, HIV positive. He has a felony from a nonviolent criminal offense. And he has just had a lot of trouble engaging or really just getting on his feet. A lot of things stacked against him. And then let's compare him with Annie, who is a woman in her early 60s, dealing with she's a white woman, she's has an education, she's medically literate. She engages with our system so differently. And so she will email me with suggestions about how to go forth in her care path, about ideas of research that she's done and how we might solve the problems she's facing. Whereas with James, I'm lucky if I can get him in the office once a year. So how do I respond to James? It has to be dynamic. We cannot be uniform in our approach to how we think about patients because they are different, and they're not only different in their context, they're different over time. So what James is dealing with now may be different from what he's dealing with in a couple years. So I think about a person-centered approach is not a luxury, it's a necessity, that we have to be dynamic and responsive to our patients.
I think it's really interesting that you've pointed out the difference in patient populations so that it's not a one-size-fits-all, but actually looking at the unique attributes of each population. Tarak, how about you?
I think this is exactly the point, is that you cannot have a one-size-fits-all kind of treatment for patients. And we need to have a fit-for-purpose strategy for each patient. We're very proud in Otsuka because we are one of the few companies that still focuses on neuropsychiatry in general, and we deal with mental illnesses. But we also know that you cannot treat a patient that has, for example, has been diagnosed with schizophrenia or bipolar disorder or major depressive disorder in a similar way. Let alone if they are of the same indication, you still have to have a fit for purpose, basically based on what Amy was saying in terms the background, the diversity, where they live, where do they have access. But when I say all of that, I think we really need to recognize that the most important thing is to have access. And still the access issue is a problem. I cannot have a fit-for-purpose strategy if the patient does not have even access for treatment. I think our system is still very much siloed, and the type of access really depends on what type of insurance you have, in a way. And even if you can have access, still we have a shortage of professionals and providers and institutions to actually treat patients. So that's something has to be an integral part. When I think about putting the patient first, this has to be at the core of what we're thinking about.
Mm-hmm. So I think that's a really key point, key takeaway point as well, which is you can't have even the most perfect patient-centered system unless patients have access to that system. Dr. McKenzie.
Yeah, I would agree with the other speakers on, the need to tailor to patients. Putting patient desires at the center of the system is critically important. I saw this, we also need a system though that, and I think this came through on the other panels, patients don't necessarily always know what they need and when they need it. And it's a system that is difficult to navigate. I saw this during my practice as a family practitioner, but then it became quite real as the mother of a child who developed chronic issues starting at the age of 4 months and still has health issues today. And so we've had to navigate that system. And of anybody that should know how to, right, I should be able to do that. But I will tell you, it is really, really hard. It's really hard for patients. It was hard for me. It still is today. Thinking about what is important to patients, right? My son's now just 2 weeks into college, right? What's important to me now is that he's able to manage his illness and that the college understands what's going on and that I have his physician being supportive of that, right? So thinking through all of those key things, but helping patients to navigate that system, regardless of, their health literacy, their background, whether English is their first language or not, whether they have a disability, what race you are, what challenges you have in your life. We need a system that works for all of us.
Great, thank you. So getting into the system, having a system that meets the unique needs of you as a patient, and making sure that it's not a one-size-fits-all. That's a great approach, a great definition to a person-centered system. Okay, so the three of you are here because you all have very unique programs that you're working on. So to the patient-centered program. So I'm going to start with you and tell us a little bit about the program.
Sure. So we have a number of different initiatives that I could highlight, but I'm going to talk kind of high level. I think about initiatives, and I have the great opportunity of working with our provider network, with our physician network, on programs that we deploy to help with patients. And I think that that's recognizes the importance of that patient-physician relationship. And then we also have programs that we work on at the plan that are directed to members specifically, right, to get them more information to help them navigate. So I'm going to speak a little bit about both. So when I think about what we do in our provider network space, one of our key initiatives is around promoting team-based care and sustainability of that. So when you look at primary care, we know that our primary care doctors are being asked to do a lot every single day with all of their patients, and there's no way that they can do it on their own. So team-based care is a care model that has continued to evolve and brings the expertise of nurses and dietitians and pharmacists and social workers into that primary care practice. Why is that important? Because patients have different needs. And it's not, you get a certain set amount of time with your physician, right, that we all know, but maybe I need help with getting transportation, or I might need help because I can't afford my medication. Well, that requires a different skill set and somebody to be able to help that physician work on that. And so bringing a social worker alongside that physician makes a whole lot of sense. And so thinking through what is the sustainable payment models to be able to promote those care models, bringing behavioral health into primary care has been another key initiative. Why? Because it's reduced stigma, right? People sometimes, maybe I'm nervous to go in and sign up for a therapy visit, but I know my primary care provider, and being able to have those resources reduces the barriers to care. It also improves access. So those are critical things that we've been doing in the provider network space. On the plan side, we start thinking through, and I heard the sessions, it was wonderful to listen to the earlier sessions about journey mapping, because we're really thinking through how challenging is it for our patients to navigate the system, particularly with complex issues? So you think about behavioral health or cancer. Those are not always the easiest things to navigate in the system. And so we're deploying resources that help to kind of come alongside of our physician network, providing some of the educational resources, but then also navigators that can help people plug into the system at the right place or help them figure out how they get care that is needed.
Terrific. Trek, how about you?
Yeah, I really like Amy's initiatives in terms of really integrating so many stakeholders in the patient journey and treatment. I think this is really important. For us, what we are trying to focus on is, the fact that about half of the U.S. population lives in areas where there are shortage for mental health care, basically, providers in general. And I think, that's going to be just the first thing that is so fundamental for us to start working on. And the first thing that we are really trying to do is to encourage and support policies that promote telehealth care in general. We know that telehealth care started with the pandemic, and it was kind of a solution that we thought will only work during the pandemic. But what it's very clear that it's something that we can leverage for the long term, especially in mental health care. And that is something we are seeing that is actually letting a patient, first of all, have a little bit more timely access and have access irrespective of the geographic area they are. But of course, there are a lot of complex policies. I'm not being naive here because there are state boundaries, county boundaries that we still need to work on. But it's a really important point for us to continue to work on. I also probably in the same context that Amy was talking about in terms of integrating so many important stakeholders and community centers and in the community in general in the patient treatment journey. That's really, really important. I think earlier we've heard from CMS, this is something that we really support. I think policy around developing the guide for not only for the patient but also for the caregiver, because we really think about the patient, but the caregiver is such an integral and important part of this patient journey. And I think every single one of us has probably, if they cared for somebody, knows that really caregiver has a big, a very important role and very big consequences as well for this role, especially in diseases such as Alzheimer's. And finally, I think in Otsuka, at the end of the day, we are in our research and development, innovation-driven company. We are very proud that we continue to develop products and that can treat patients with schizophrenia, bipolar disorder, major depressive disorder, and some other rare diseases such as, just newly we launched agitation, Alzheimer's disease. But we are also trying to find solutions beyond the traditional drugs and assets to treat, which is more related to digital solutions. I think digital solution is another tool that patients and physicians can actually use. It can leverage the fact that you can access them much more freely, at the time that you actually need them, but also allows you to have so much real-time data and interaction to help the patient in their journey, the patients in their journey.
Great, thank you. And last but not least.
Yeah, such great examples and so many avenues to improve our system. One of the things that I really appreciate about working for Kaiser Permanente is that we're a learning organization. And I do think that is really a cornerstone also of a patient-centered or a person-centered healthcare system, is being able to adapt and recognize, try things, learn, make errors, and then recognize them not as a loss, but as something that you build on to improve. So that way we can continue to improve higher quality, safer, more efficient care, and also engage and capture members that may not be connecting with us. And one of the things that we were realizing was that there were a certain subset of patients who were only using our services in very limited ways. And so that might mean that they would only see us in urgent care. And then we weren't really able to capitalize on how to help understand what's important to them, what needs they have, what barriers they have. They may only see us for their flu shot once a year. And we know that there are needs that perhaps we're not recognizing, we don't hear, we don't understand. And then the one that we decided to engage with was persons who are only seeing a medical specialist. So they never connect with their primary care medical home. And what we did was we had, dermatology in particular being a very fast-paced specialty. So, visits are very focused, the turnaround is very quick, and there's not a lot of extraneous time to be thinking about what else does this person need? How can we serve them? So what we did was we started offering video visits. The person would come in for their dermatology visit, and we would see if they had chronic conditions that needed to be addressed, or if they had open care gaps, which our electronic medical record also prioritizes according to the person's risk. And it says, this person is due for X, Y, and Z. So we would offer them at that time to come in for a video visit. Just they didn't have to leave the building. They walked into a different room. It helped us to have people understand or break down barriers to a new system, a new platform with digital care. And then we were able to, as a system, understand, what were the barriers that were perhaps presenting, or how could we make them informed about various things that might improve their quality of life? Or what are the social determinants that may be playing a role into why they are using the services the way they are? And from a patient side, it's been very well received, because they feel very satisfied that they've been able to get their immunizations on the same day, or they're able to go down to the lab or be reminded about a medication refill. So we are now going to expand that into our flu clinics, where people will come in and hopefully be offered the same services.
That's terrific. So each of you have mentioned the engagement of patients. Talk a little bit, and I'm just going to open this up to the panel. Talk a little bit about how you designed these programs, and did you do it with patient input? Was it top down or was it bottom up? And how do you know that you're addressing the actual needs of the patient?
I can start. Sure. We are increasingly incorporating patient surveys as well as physician surveys. They're a stakeholder in this as well, and we recognize that we can't deliver the outcomes to patients if providers are suffering. And I heard that earlier on some of the other panels and wholly agree. But we're incorporating patient and physician surveys about the work that we're doing, as well as the journey mapping, and we're including patients. We have many initiatives. We have many of our quality initiatives that have governance boards where patients are actually sitting on those boards. I think about one of our oncology quality initiatives, and we have patients that not only sit on those boards and help kind of direct the direction of the quality improvement activities by saying, this really didn't work for me, right? These are where I'm having challenges. But they come and we have routine meetings with the physician stakeholders that are involved in those quality initiatives, and patients are speaking to the physician so they can hear that patient's voice firsthand, right, within our network. And we think that that is really critically important in being able to shape kind of how we continue to move forward.
I'll add that especially recently, I seem to be making myself aware of this every week at least once, of how many assumptions we make. And we do so based on expediency. In fact, we just had a program where we were saying, let's figure out if our population health outreaches should be one by one, or if they should get a monthly letter that says you're due for all of these things and here's how you can get them done. And we had this internal debate, which was really interesting, about, well, should we do it the right way or should we do it the fast way? So, and people were saying, it'd be great to get patient or, our member input about this, but boy, isn't that going to slow us down? So it's really interesting that we have to really acknowledge our own biases, our own, we all in healthcare, we have so many pressures for outputs and metrics and regulatory, and so we have to slow down, and we have to acknowledge that understanding what our members need is really the only way we're going to get to where we need to be. And that's where I like to think about, this circular pattern of a patient-informed or a person-informed, and then the system adapts. And then we get reactive or proactive feedback, and then we adjust. So it's these plan, do, study, act cycles of repetitive learning.
And you mentioned that there's a slowness to it, but it's done in real time, I'm assuming.
Yes, yes. So that we really have to make sure that we are soliciting that feedback and engaging in the process and the development. So at any stage of the process.
Excellent.
Yeah, I think, data analytics are so important. They are getting more and more democratized, if you want. And I think also technological abilities is helping us to maybe individualize the solutions at some point in time. But I was listening to all of that, and I really loved your humility in a way, because it's really very tough. I mean, we're dealing with very complex issues, and we know that even if we really understand all what the patient goes through, we understand that there are other stakeholders, including the caregiver, that we need to understand, including insurance, doctors, all of these important aspects of it in order for us. We need to really have insights along all of these stakeholders in order for us to have the perfect solution. So we need to be humble and understand that this is constantly changing. Our ability to understand more is actually increasing, but it starts with an attitude. And I'm really proud that we have teams that are very much focused on this, but we need to understand that we'll never be able to get the perfect answer. And we'll try something. If it doesn't work, we'll try something else.
So I think that's really key, the idea of getting from the patients what they most need from a system, trying different approaches to that, what works, continue on, what doesn't, set aside and refocus. So each of you have very successful programs. What were some of the challenges that you faced, and how did you overcome some of those challenges? Who'd like to start?
Yeah. Please.
What's unique about Kaiser Permanente is we don't have any challenges. So.
This is good to know.
It's been delightful.
Good to know.
Next. One of the things is we really want to live up to our promise of being an integrated care delivery system. And so part of that expectation is that whether you are in rheumatology, behavioral health, orthopedic surgery, that we're going to be addressing you and your needs as a whole person. And so we would be screening for depression in a rheumatology visit, or a general surgeon would be reminding someone that they need an osteoporosis screening, or that we would be checking social determinants or smoking history when they're being rheumed, and that there is action taken based on what we learn, and setting people up with the resources that we know we have. So one thing, though, that is a challenge is that, a team of teams was mentioned earlier. We are one team working to serve our patients, but we have so many demands within those teams. You have a fire burning here, you have urgency of this, you have access demands, you have provider satisfaction reports, you have various inputs that your teams are trying to address on their own. And it's so easy for us to forget that we are one system working together with the member at the center. So that even though that is our model, and we strive to be that, where we are providing this unified care that focuses on you. You are the most important person to us at this moment. But we have to get through all of those practical barriers, as Tarek was mentioning, those difficult things that then we find up that within our teams we have competing priorities. So it's a constant cycle of education, reinforcement, reminder, centering, measurement, and accountability.
Okay.
I would agree that kind of that integration piece is a key challenge. I think we all face that. Another one that I would touch on, and I heard this earlier, is, we have a lot of priorities, right, and stratifying those. We know equity is a key thing that we are driving toward. We're not going to achieve our goals if we don't have a system that works for everybody. But we're also doing all of this in the face of post-COVID and workforce shortages. And those are very real. We're hearing from our physicians, our practices, our health systems every day about this. And so I'm not going to sit up here and say, we have all the solutions. I'd love to say we have no problems at Blue Cross of Michigan, right? It's the same thing. But we are committed to partnering with our physicians and thinking through how do we operate in what we have today, right? How do we create more efficient systems? And that can be done through policies, that can be done through care models, thinking through, I mentioned earlier, team-based care and collaborative care. Part of the reason that those are so important is it's bringing additional resources to provide access where we know there are challenges, right? And expanding that access for patients and bringing it right into the primary care setting. We're doing that with enhanced payments to try to help support the system and support the transformation that's required in order to be able to do those care models. None of this is easy, right? This isn't stuff that you just, I learned that when I was in residency. No, this is like a practice that now has to completely transform the way that they're doing care, and that requires investment in funding and sustainable payments as well. And so we are committed to that. Policies, like we talked, I think, a little earlier on some of the panels about telehealth and expansion of telehealth. That's a great way to enhance access as well. But then you think about the equity. Not everybody has access to video or internet. Like, we have very rural areas in Michigan that we have to think about as well. And so our policies have reflected that by also allowing payment for telehealth through a phone visit only, because most people have access to a phone, even if you don't have access to broadband internet or whatever. So I think thinking through how we are operating, we all know that there are workforce shortages. How do we continue to change policy and enhance care models to deal with what we have today?
I agree. I think these are really great points, and I tend to agree. I think the latest report from Mental Health Americas basically says that 20% of adult Americans suffer from some kind of mental disorder. That's a lot. That's 1 out of 5 adults. Thinking about this room, we have a little bit more than 100. That's 20 plus. And more challenging is that we know that half of these people are not able to get treatment. And that has devastating effect. We see that every day on the news. We see that, in our own family stories, in our team worker, family stories. And we know this is this is putting an amazing burden on the healthcare systems, but also on society as a whole. So something has to be done. And I agree from a parity perspective. After the pandemic, we've seen a little bit more of this gaining traction. We've had legislations for parity for such a long time, but we just started to see some of the let's say effects of that in a positive way. But from a chronic mental health care perspective, we're still lacking behind. And the biggest impact is really on these underrepresented communities, people living in remote areas. Depending on your race, on your gender, you may not have the same level of treatment. These are the biggest challenges that I think we are facing.
So given the challenges that you just articulated, as well as some of the benefits, what is it about the private sector that allows this kind of innovation that you've been talking about today? Sometimes, all of us who have been in healthcare for a while have seen that the federal government will try something and the private sector then adopts it. That happens a lot in the Medicare program. But other times we see the private sector innovate. So what is it about the private sector that's allowing some of these innovations that you've talked about today in patient-centered care?
I might start with just saying that I would like to say we're more flexible than we are. We're a huge organization. But I do think that when we take it down from to the level of rather than having things being top-down, that we look at where the teams are innovating themselves and really responding in a way that we can support that innovation, we can support creativity, and that we don't have to be a rigid system, so that we have teams that are trying new things and that we support that. So we had a neurology team that was looking at how to avoid persons going to the emergency room for a recurrent seizure. And the point was, the emergency room is not going to do anything for that person. And so what again, what I love about our system is that what is right for us, meaning someone is not overutilizing an emergency room, is right for the member, because that is a lot of money to go to the emergency room, and that is a lot of stress. So how do we support that person to know what they need to do at home, their caregivers? How do we make sure that they have the resources, the support to understand what would happen in this moment? How is this going to play out? What's it going to look like? How do I explain to you and support you as a person who is afraid, or as a caregiver who is afraid? Mm-hmm. So I think that when we can allow our teams within an organization to spontaneously create and encourage that, and to foster that, and then to celebrate it. And also to celebrate when things didn't go as planned, because it's a learning opportunity.
Thank you.
Yeah, I'm going to build on that because I love that. I think that is a critically important part, is having that flexibility. I would say that, in Michigan, we've seen some real magic as well in doing that in partnership with our provider communities. I think about they're called collaborative quality initiatives, and there's over 20 of them now, and the oldest is over 20 years old. We started in an area of cardiac care that, care was not well defined, or quality care was not well defined. And we brought specialists together to say, what can we do to improve the quality of care? Help us to track this, measure it, do a PDSA cycle, right? And then teach your peers. And we've noticed that is a great way. It allows that, and we help fund it and partner on it. But we've noticed that's a great way to provide enough flexibility within the system to do those cycles, right? And what we don't, what doesn't work, we put aside. It brings together peers to drive some of that learning, and it's just been a very successful way. Doctors like to hear from their peers. They like to learn from other doctors, right? And we recognize that. We have a role to help partner in that as a health plan, but don't necessarily need to have the strict, like, here, do this, right? We are not in the best position. We bring together the best people in the market, the cardiologists, the oncologists together to drive some of those shared learnings, and that's where we've seen a lot of flexibility and change.
Yeah. I honestly think building an ideal system is not something that one sector or one company or one party or one stakeholder can actually do it. I feel that the private sector in general, maybe to answer directly your question, maybe some of the companies that are focused on innovative solutions can actually showcase some of these solutions, be able to work and finance and invest in ideas that can showcase and provoke others to do the same. But the way I think about Otsuka is really more a bridge builder. Because we realize that we can't do it alone. I don't think any of the stakeholders or any of the other big players can actually do it alone, no matter how big your size is. And thinking about ourselves as a bridge builder, that is ready to host a good discussion around policy, advocacy, some innovative solutions, be able to put, investments behind showcasing some of these ideas is a good place to start.
So I want to build on that. What, both in terms of getting rid of barriers and also building on some of the successes of your programs, what do we need policymakers to do? You have a very attentive audience here. Everybody wants the answers.
So I think I'm going to step in and I'll start off and others can weigh in. But I think thinking through how we continue to partner on models of care. We talked about, there's multiple stakeholders in this system, right? You have payers, you have consumers, you have employer groups, you have physicians, you have patients, right? And thinking through how we make the system easier for our physicians is a critical part of that, because otherwise it drives confusion, it drives burnout, it drives people retiring earlier, which just worsens all of these access issues, right? And so thinking through how we can partner together to drive care models that we know are effective, that are proven in the literature. We think about collaborative care or team-based care, and how we can partner on some of those models to drive them forward. Consistent payment, consistent measurement, those are the things that our physicians are asking for. But then how do we also think about how the whole system's working together? I think there have been some amazing models, as you've mentioned, that have come out of Medicare. The ACO models, we have the primary care models, and we have specialty models. How do those integrate and fit together, I think, is where our plans are all working to try to figure this out and think through how do we make sure that all parties are invested. The challenge becomes when you have a patient who has diabetes and they're seeing their primary care provider, they're seeing their endocrinologist and their nephrologist, right? And as we think about how we're continuing to evolve payment models, we know that we're kind of moving toward increased accountability, right, for physicians and for providers within the network, because that helps to kind of take off some of the constraints. But how do we do that in a way that is cohesive and works together? So I think is a critically important part of it.
I think for me, I totally agree, on Amy's comments here. But the way I sometimes, would like to see from policy is taking, specifically the theme of this, taking, the individual patient into consideration. And I think in a very good way, sometimes we try to put policy that can fit as many patients as possible, but we miss some really important segments of the population, in terms of what kind of quality treatment do they actually need, what kind of access treatment they usually need. And I do agree. Even in a big organization, sometimes you put lots of regulations and policies, but you need to be very careful. Every time you put an additional policy or an additional regulation, you need to take into account what you have done before and how would this impact that. So I love your approach. I think a more holistic look and and take into consideration the evolution of the system will be extremely important.
I would probably I think about my primary care colleagues, and primary care is in a lot of distress, I think, pretty much across the board. Really one of the lower incentivized specialties. We are seeing medical students stray away from primary care and into specialty because it's a very difficult area. But yet when we think about a person-centered healthcare, who's going to be the glue that holds things together for that person? Who's going to know them for decades and really understand what's happening in their world? I can relate to this in some degree as, sort of the equivalent of a primary care provider for some of my HIV-positive patients. I know things about them that are really going to impact their lives, their well-being, and their safety. But if we don't prioritize a relationship with a central provider, which in most cases would be a primary care provider, we really risk just contributing to a frayed system. So I think incentivizing primary care over specialty, or at least equally, perhaps not over. But then also when we think about the volume-based or drives around volume, that is really a disincentive for people. It burns out physicians, providers. It's a disincentive to know people, to be a stable force for them. And so if we think moving towards value-based care, that's better. But I liked earlier what people were saying about, gosh, we really have to honor a qualitative experience as well. Because that is, that's really key. It goes towards how is that person experiencing our system, let alone like what are we doing for them to help their prevention.
That's great. So you mentioned a quarterback for care. We've talked about special populations, particularly populations that have mental health problems that need special attention. Lots of conversation in the healthcare debate today around health equity. So as we are building a system that is more patient-centered, patient-first, how do we address the unique needs of what's quickly becoming multiple different populations with specialized needs, difference in geography, difference in ethnicity, you name the difference, it's there. How do we build a system that addresses the myriad needs?
We talk about equity pretty much every day in every system that we're working on, and it is so key as a component of being a successful organization and really living up to providing person-centered care. I think about three things that we do that help support that, and one is systematizing our approach so that we remove our intrinsic biases. We help to make things neutral. So for example, we would have registries of persons who have certain conditions. So let's take someone has a lung nodule. And we have a registry list of 475 patients who have a lung nodule that needs some sort of follow-up. Now that is a list of names. It has nothing to do with where they are. Now you could argue that certain people are going to need different outreach there, but it also, I think, just acknowledging where we are from the beginning, that our care is, we need support in our care to make sure that it is equal, that we're providing the same message to the group. So those people will get an outreach from a bulk outreach that says you need this study done. And then the pool gets further narrowed down because a certain percentage of those people followed up and then others didn't. So then what did we need to do differently for that group who didn't follow up? And then further, then to the next people, do they need a care call from a care coordinator? Or do they need something else that's helping to inform why they're not? Are they afraid? Are they worried about cost? Are the hours not compatible? Do they have transportation issues? So that's one thing. The second is correcting, being aware of our biases and then course correcting when we find them. So an example of that was with the Mpox, or previously called monkeypox epidemic that we had last year. We were designing systems to prioritize vaccination. And we were determining, it was based on, according to the state health department, sexual orientation. And then as we started to put this through, we thought, well, this really doesn't have anything to do with sexual orientation. It has to do with risk behavior. So there was a bias there on the part of, on a large scale for policy development around who gets this. Well, it's a gay man who gets it. Well, why is it a gay man who gets it? What are we making an assumption about that person's behavior and risk compared to a heterosexual person? So that was an interesting, but course correcting as we learn. And then finally, we had an opportunity to have a medical student work with us to personalize care and get a better understanding of what people's experiences were with our system, because we had, for example, Black and Latinx persons who were not linked to a primary care provider, who were due for either colorectal cancer screening or diabetes screening. And we had this person make phone calls, individual personalized phone calls, to inform them, ask them about what they needed. And then I loved it because the medical student got to really upfront learn early, this is not easy for a lot of people. And then to understand, we learned what can we do differently? What is the information we can glean that from these people to help them make sure that we create a better healthcare journey for them? So it was a great learning opportunity.
That's terrific. Anything else to add?
Yeah, I'll add on. We utilize some of the same things that were described, registries to remove some of the implicit bias. This kind of standardization we found to be very beneficial, addressing implicit bias within the system, both through trainings of our physicians, but also office staff. You know, you think about, that's the first people that individuals encounter when they come into a healthcare system. If you have a bad experience right at the front desk, are you coming back? Probably not. But I also want to hit on the other side of this of, thinking through what do we do to address people flexibly in the needs that they have around social determinants. We know that that's a significant contributor, even more so than the healthcare that you're getting in the office, oftentimes, of your outcomes if you have a social barrier. And so we are starting to create investments in different types of providers that have more lived experience. You think about community health workers, right? We know there have been multiple studies out there that have demonstrated the benefits of incorporating community health workers into teams. They have that lived experience, they have the credibility within the community, they know the community resources. And so we found tremendous benefits and are putting money behind that and creating investments to support that within the community. We're also beginning to look, and I know others are as well, at things like Area Deprivation Index, which provides kind of some geographic understanding of where we have more disparities and where we have more social challenges so that we can think about what resources do we need to deploy into communities and with specific providers. It might be that provider's quality score is low because they're just not doing the things that they need to do, but it also may be that because they have a population that has lower health literacy, has challenges in transportation, may have distrust of the system. And so we need to think flexibly about where we're getting resources and how we're creating measurements so that we're not worsening disparities, but starting to lean into those.
Great, thank you.
I think for us, really, we are committed to include diversity, equity, and inclusion in our research programs. That's obviously a critical function for us, and including patients of different, genders, race, irrespective of where they live, is very important. So we're really implementing and including now virtual clinical sites, leveraging telehealth. That's really important. And it's really paying off because it's helping, first of all, to enlarge the patient population that we can include in these clinical trials, but it also helps us reach places where traditionally we were not able to reach. And the second thing is, of course, we're trying to utilize non-traditional sites such as pharmacies, community centers, and we are also deploying e-consent, which gives us leverages a little bit multimedia, gives better education, awareness. This increases the ability of patients to consent and participate in the clinical trial. I have to give really a positive nod to recent legislation as well that includes Medicaid patients in clinical trials. This is a population that we have not included traditionally, but the recent legislation actually pays for Medicaid patients to participate in clinical trials, which is something extremely positive and will help us a lot in this approach.
That's great. Thank you. So we knew that this hour was going to fly by. We could sit up here for another 2 or 3 hours with additional questions. But I promised the panel we would end with what I hope will be a fun question we're going to do. We have 1 minute, so we're going to do this speedy. So you are king and queen for the day. You can design a healthcare system for the patient. Very quickly, what would it be?
So I pick up the phone, and every provider that is involved in my care has access to all of my information. They're all talking to each other to coordinate my care. I know easily where to go and get care, and they prioritize the things that I want and that are important to me.
Terrific.
Yeah, and for me, it's really a system that takes in consideration a crisis, acute situation, but builds on it for more, chronic follow-ups if this is needed.
Absolutely.
Last 20
word.
seconds.
Counting down.
Yeah, no kidding. A system that knows me, a system that understands the barriers that I uniquely face in the time that I need them, and agree with the coordination of care communication.
Great. Thank you very much. So we know we stand between you and lunch. So please join me in thanking our panelists for a great conversation.